Welcome to Acid-Base Balance. Today's lecture is going to be an audio online PowerPoint so that you can prep with this information ahead of time and then come into class, and we'll do some ABGs in class, kind of like what we did with the ECGs. And we will also go over some case studies so that we can talk about what we would expect with certain patients and their presentations. Some of the things that you need to do before you start this PowerPoint is you needed to do your reading. You needed to go over IGI Chapter 14, which is the chapter on acid-base balance, and you might even need to go over Chapter 13, which is the fluid and electrolyte chapter, so that you can review the different things about electrolytes and fluids, how they move, so that this is not so foreign to you. The other thing is you need to know terms. You need to go back and know what hypoxemia means, acidemia, alkalemia. You need to know what the different chemical letters mean, such as hydrogen. What is the letter for that, which is H+, or bicarb, HCO3, carbon dioxide, pretty common one that we use, CO2. Also, we'll be talking about the different terms related to blood gases, so the PaCO2, partial pressure of the carbon dioxide. Also, we will also have PaO2, pH, you'll need to just feel very familiar with that so that when you get to the sections here, it's not foreign. So if you haven't done that, I'm going to ask you to stop the PowerPoint and go do that. One thing that is good about a PowerPoint is that you can stop if you don't remember and review. So that is the good thing. This was one of my first PowerPoints that I started doing where we would do an activity in class, and of course it's expanded to quite a few more, and I really like being able to practice these concepts in class after I've introduced them, so I hope you will too. So let's get started.
Today's lecture is we are going to discuss the mechanisms that maintain acid-base balance. We're going to differentiate between respiratory and metabolic alkalosis and acidosis, and we're going to identify the laboratory and diagnostic tests used to determine acid-base balance. So first let's talk about the basics of how is acid-base regulated. Now hopefully some of this comes to your mind when you remember physiology, so many years ago. Something that you would wish that you didn't have to remember again, but you do. So here we are. How is acid-base regulated? We're going to be looking at just the basics today. We're going to look at basic ABGs. It's kind of like the ECG lecture. We're looking at basics so that we can get you up and running and comfortable with this, so that when you move into third and fourth semester and they start talking about partially compensated and compensated acid-base balance, you will be ready for it. So, how is acid-base regulated? Well, when the pH rises or falls, and remember the pH needs to be 7.35 to 7.45. It's a very tight number in our blood that it needs to be. When it changes to either acidic or base, there are three regulatory systems that come into play. And here are those three. The three are the buffer systems, the respiratory system, and the renal system. Let's talk about each of those specifically. The first one that we're going to look at is the chemical buffers. What they do is they absorb any excessive hydrogen or acids. They are the first line of defense. They act immediately. And they act immediately to protect your tissues and your cells. They act to neutralize the acid or the base. It can actually take care of that as well, until other regulators take over. There are three different types that we typically look at, and that is the bicarbonate buffer, the phosphate buffer, and the protein buffer. Now the protein buffer is the most common, and in this group is included your albumin, your globulins, and your hemoglobin. And so these bind with your HCO2. And so you can see that when we talk about the patient has a low albumin or a low hemoglobin, this is going to impact their ability to utilize this as a chemical buffer. We'll talk more about this later on. The next system is the respiratory system. This is our second line of defense against acid-base imbalances, and it occurs within minutes. It can either stimulate us to hypoventilate, breathe more slowly so that we retain acids, or it can cause us to hyperventilate so that we excrete acids and breathe much more quickly to get rid of those acids. So the lungs regulate our carbon dioxide, and our carbon dioxide combines with water to form carbonic acid, and this is part of that acid-base balance. I'm not going to have any questions about that specifically, but it's just so that you understand it fully. And even though you look at my PowerPoints and maybe you understand what's going on there, you got to sometimes go and read more sources so that you have a full picture and a full understanding of what's going on, so that when you have something asked a little differently, you still can understand and respond appropriately, especially when we're talking about tests. So we talk about the lungs are regulating the carbon dioxide, and so the chemoreceptors in your brain, in the medulla of your brain, are going to sense that there is a pH change. And based on that pH, them sensing that the pH has been changed, they will then vary the chemoreceptors in the medulla will vary the rate and the depth of your breathing to compensate. So if our pH is low, that means we have too much CO2 or too much acid, too much HCO2, too much carbonic acid. And so it's going to increase our respiratory rate so that we blow off CO2, we blow off acids. If our pH is too high or more acid, more alkaline, not acid, more alkaline, more base, then that usually means that our acid levels are low and our CO2 is typically low. And so if we slow down our respiratory rate, we can retain that CO2, and that will help us to raise that pH. So you can see how those chemoreceptors respond to try and help us with any changes. And we can assess our ventilation by looking at the PaCO2, the partial arterial pressure, arterial pressure of your CO2, and we typically don't even call all that. When I say this is the legal name, PaCO2, but you'll see all the nurses will just call it your PCO2. So we're just asking for what is your CO2 in your arterial blood gas, and it should be 35 to 45, and that will give us a clue if there's any problems or any compensation there. The next system is the third system, is the renal system. This is our third line of defense, and it usually occurs within hours or days. But even though this change is slower, it is stronger than the other two that we've previously looked at. This is the kidneys, where the kidneys will either excrete or conserve acids or bases, depending on what the problem is, into the urine as needed. Also, not only can it excrete and conserve, but it can also produce bicarbonate HCO3. And so we can see the function of this by looking at our arterial blood gas and looking at the bicarbonate, the HCO3. And when we look at that, we will see normal should be 21 to 28. Now you will see in some books it's 22 to 26, and I typically will go there because that's older school. But internationally, they've made some changes, some international units, something lab thing, and now it's 21 to 28. So for purposes of testing, it's 21 to 28. Now, what is the reason we're so concerned about acid-base imbalances? Well, when an acid-base imbalance occurs, it's going to cause problems with it's going to cause our hormones to become imbalanced. It's going to cause our electrolytes to become have an imbalance. We're going to cause our cells to become much more excitable, and it's also going to decrease drug effectiveness. So when any of these things happen, this is going to cause a domino effect of problems in our body. So this is why we don't want an acid-base imbalance. Now, acid-base imbalances are classified in two ways. They're classified as either metabolic or respiratory. And so this is usually based on what's the primary cause, what's the original reason why the pH changed, whether it was respiratory induced or metabolically induced. And then the second way that we classify it is whether it's acidotic or alkalotic. Is the pH low, so it's acidosis, or is the pH high, so that's alkalosis? So we are typically looking at respiratory acidosis, respiratory alkalosis, metabolic acidosis, or metabolic acidosis or metabolic alkalosis. Today we are going to look at what we call primary imbalances. That's where there's only one cause, and we're going to look at it without any compensation. One cause would be where, such as respiratory failure causes respiratory acidosis, or renal failure causes metabolic acidosis. And so, but the thing is that we have to remember is that our body is a beautiful thing, and it really wants to compensate and keep us balanced. So it does make changes through those three different systems. Remember the chemical buffers, the respiratory system, and the renal system. It will make changes and compensate to try and bring that pH back into a normal range. That's called compensatory response. And we are not going to study that today, but you will study that in third and fourth, and obviously every patient is going to have compensation. Another thing that can occur is mixed imbalances, and that is when both metabolic and respiratory imbalances are present. And the most common one that we see in the hospital based on this is when a cardiac arrest causes respiratory and metabolic acidosis. So that's when we're really dealing with two problems. But really, usually there's one thing that started it all. There was a primary imbalance, and that's what I always look at, because that's what we really have to fix, even though the body might be compensating. So here's a picture I stole from Nursing Education Consultants. Really, actually, we do have their book. That shows just a visual picture of alkalosis, where you can see the K, it's kicking the pH up, and acidosis is D, sliding the pH down. So hopefully that visual helps you. Now let's talk about acidosis, and then we're going to look at respiratory acidosis and metabolic acidosis. And then after that, we're going to look at alkalosis, and then we'll look at the respiratory alkalosis and the metabolic alkalosis. I'm doing this a little different this time. I'm hoping that it makes it clearer. The good thing about doing it on PowerPoint here, we can discuss it in class and clear up any things that aren't clear. So, acidosis. Let's look at the cellular pathophysiology. Now, to tell you that I'm simplifying this to the hilt is an oversimplification. But let's look at it, and hopefully this makes it easier for you to be able to function with ABGs. Acidosis. Well, pathophysiology on the cellular level we're going to look at. We're going to look at this and we're not going to decide whether it's respiratory or it's metabolic. We're just going to talk about the pH has become acidotic, and this is what the body's going to do as a result of that. Okay? So as the pH goes down, the hemoglobin is going to release the oxygen that it has on its cell, and it's going to pick up the hydrogen and the CO2. So this is one thing that happens automatically. It's trying to compensate It's trying to pull that hydrogen out of the blood and onto the hemoglobin. And so what happens is that's a great thing to happen, because now our pH is going to increase, but we've just lost oxygen off of that hemoglobin, and so our O2 sats are going to go down. This is not good. As we continue along and the hydrogen or the acid increases, the CO2 increases, the acidic state continues, what's going to end up happening is it's going to stimulate the medulla in the brain, and this is going to, remember, those chemoreceptors are going to increase your respiratory rate to blow off the excess CO2, to try and bring that CO2 down. Another thing that this is going to stimulate or cause, it's going to cause the cerebral blood vessels to dilate. And as they dilate, there will be increased blood flow to the brain, but that's going to cause a problem. It's going to cause cerebral edema. And this cerebral edema will then end up depressing the CNS, lowering the activity in the CNS or in the brain. So your central nervous system will be slower to respond, and we call it's depressed. Another thing that happens as this hydrogen, the acid goes up, as the hydrogen accumulates and the CO2 accumulates, is it's going to stimulate the kidneys to retain bicarb and sodium. It's trying to compensate. It's going to excrete more hydrogen ions, and it's going to utilize the bicarbonate to buffer the hydrogen ion. So what will end up happening with this is a good thing. Your pH is going to increase. You're going to see more hydrogen ions or more acidic urine. You're going to see your bicarb increase in your blood, and also as a result of this, your respiratory rate will slow down. As we continue on, the hydrogen starts to move into the cell. Remember, everything has to be balanced, and when there's too much hydrogen outside of the cell, it's going to move into the cell. So as the hydrogen moves into the cell, the potassium is going to move out of the cell to maintain electroneutrality. And what's going to end up happening is we're going to see hyperkalemia. And of course, with hyperkalemia, we have to worry about arrhythmias. As we continue, the oxygen is going to drop lower, the pH is going to drop lower, and this is going to continue to depress our neurologic and cardiac systems, resulting in our level of consciousness being diminished. This patient will subsequently go into a coma. So what are the signs and symptoms of acidosis in general? Acidosis, you'll see on this PowerPoint that I highlighted the D on the acidosis, and it's to try and really focus to you that this is going to be a depression of your CNS, your neuromuscular systems, and your cardiac systems. So let's look at the specific changes. Now, the reason that these are depressed is a specific reason. It's related to the hyperkalemia that has resulted, and it's related to the elevated CO2. These two items are what are making the changes throughout our body and causing this depression. In the CNS, what we'll see is confusion and lethargy. I don't have the GI tracts. Remove that one. I'm not talking about. Neurovascular changes. You'll see hyporeflexia, and you'll see muscle weakness. Cardiovascular changes, we will see bradycardia, see more depression. In fact, it can even go into heart block, first-degree heart block. We can have also hypotension and thready pulses. Respiratory-wise, it depends on what type of focus is it. Is the primary cause respiratory, or is it metabolic? Because we'll see two different things with this. With respiratory acidosis, we will see the respiratory changes that we will see is we will see a rapid shallow respirations. with the metabolic acidosis, we're still going to have the rapid, we're going to still have trying to blow off the CO2, but the difference is that this is a hyperventilation that's in really a very deep respiratory rate, so it's very fast. The most common one that we refer to on this one in metabolic acidosis is when a patient is in DKA, diabetic ketoacidosis, and they have Kussmaul breathing. That's that. Did I do that well? Anyways, usually I start coughing when I start doing that one. Anyways, other things that we see is an integumentary. We will see changes based on where the focus is here. If it's respiratory, we'll see cyanotic changes. But if it's metabolic, we will see warmed flesh skin. So very different based on what the cause is here. Also, we are going to see hyperkalemia. That K is going to go up. As that K goes up, we're going to see all the signs and symptoms of hyperkalemia. And one of the ones that we typically see is that bilateral weakness and like paralysis that can occur. Now, let's look specifically at the two different types of acidosis that we can have. We can have respiratory acidosis and metabolic. So, respiratory acidosis, the cause is where there has been some kind of hypoventilation of the alveoli. And so, as a result, carbon dioxide has been retained, or what you should always remember is hypercapnia. I think that's an NCLEX sort of question. So that's probably good to remember what hypercapnia is. So what are the four, so you can see here, I think I have some pictures here of how the CO2 goes in. Different ways. Emphysema can certainly cause this. Pneumonia can cause this for totally different ways that they cause it. So let's talk about that. Let's go to the next slide. Okay, so the different etiologies that can cause this, the four main reasons is either, and I'm going to say them right up front and then we'll go over each one, respiratory depression, inadequate chest expansion, airway obstruction, and reduced alveolar capillary diffusion. So let's look at the respiratory depression. Now, in respiratory depression, one of the most common ones that we see in the hospital is caused by medications, such as narcotics or hypnotics or sedatives or anesthetics. So this is a really common one that we worry about in our post-op patient, respiratory acidosis. Another one that can cause respiratory depression is cerebral edema, and this can be caused by a head trauma. It can be caused by water intoxication from drowning. There's lots of different ways that this can happen, but basically what it is your intracranial pressure has increased to such a point that you are leaking fluid into your tissues of your brain, and this will cause changes to your respiratory system. So, but the most common one we see is the medications. Another cause of respiratory acidosis is inadequate chest expansion. And going back to respiratory depression. So obviously, if you're so sedated and you're so affected that you're not breathing deeply, then you're going to have that hypercapnia occurring. You're going to have that exchange, that hypoventilation at the alveolar level. So now let's move to the next one, inadequate chest expansion. This can be due to various different reasons. Chest trauma is one reason, such as a rib fracture. Another one can be muscle weakness. This can be caused by various different degenerative neuro diseases, such as muscular sclerosis. It also can be from external constriction, such as obesity can cause a constriction to your ability to take deep breaths, as well as ascites. And you'll see in that picture in the very bottom right-hand corner, that's a man with ascites, and you can see how that large abdomen filled with fluid is pushing his diaphragm up so that he's not able to breathe as deeply. So too does a patient that is morbidly obese will cause the same problem to their diaphragm. And then, of course, respiratory arrest is another thing that obviously they're not adequately expanding their chest. So when we can't adequately expand our chest, that's going to cause problems with our ability to ventilate. We're going to cause hypoventilation. We're going to end up with hypercapnia. Airway obstruction is the third one. Airway obstruction can be internal or external. Internal obstruction can be such as something like retained secretions or mucus. A really common one that does this one is our patients with cystic fibrosis. They're not able to break up those mucus and secretions well enough to bring it up. Another one is bronchoconstriction or laryngeal spasm, such as with asthma. So this is causing an internal obstruction. You're not able to get the air in to the alveoli, and so consequently you're not able to perfuse. External obstruction is another one, such as neck edema. This is one of those ones when we talked about oral cancer and having a radical neck dissection. This can cause swelling externally to the area, and so then the patient might not be able to breathe as deeply as they need to and end up with respiratory acidosis. The fourth one is reduced alveolar capillary diffusion. This can occur in acute pneumonia. We have a lot of patients with that, as well as COPD, also known as emphysema. Drowning patients fall in this category, as well as pulmonary edema patients fall in this area. Pulmonary edema can happen for various different reasons, but bottom line is that there are fluids or secretions or something in the lung that's preventing it from actually allowing the oxygen and carbon dioxide from moving across that alveolar capillary area, and so the diffusion is reduced, and so they get in trouble with having not enough O2 and having way too much CO2. This all can occur acutely, or it can occur on a chronic basis. If it's acute, we're going to see the pH drop below 7.35, but if it's chronic, often the pH will remain within normal limits because the body compensates, and it compensates for quite a long time. Some of the labs that we're going to look at with respiratory acidosis is we will see that the pH is going to be down, 7.35, showing acidosis. Our PCO2 is going to be elevated. We're going to have a lot of acid there. So normal is 35 to 45, and we're going to be above 45. Our bicarb is going to be normal. Our HCO3 will be normal, 21 to 28 or 22 to 26, depending on which book you're looking at. But our PO2 on our whether it be on our oxygen saturation or in our blood gases, will be down. Electrolytes will be potassium will be elevated. So what is the collaborative care for this patient? The collaborative care for this patient is treatment is going to focus on improving the ventilation. So we want to focus on the airway or focus on the gas exchange. If it's a non-pulmonary cause, we're going to treat that underlying cause. Otherwise, we're going to typically focus on a pulmonary issue. So obviously, we want to intervene here and increase their ability to ventilate, but we always have to be thinking in the back of our mind, what is the cause, what is causing this problem, and removing that cause. So medications, if it's causing ineffective breathing, we certainly want to come in right away with oxygen for this patient. Remember, in the back of your mind, have caution with your emphysema COPD patients, because we do not want to wipe out their drive to breathe. So those type of patients, we certainly don't want to increase the oxygen levels beyond a point that's safe for them. Other medications we would consider are bronchodilators to open up that constricted airway, mucolytics to try and break up the mucus, Anti-inflammatories, especially this is true for our asthma patients, trying to slow down that inflammatory response. We want to consider any kind of drugs that would treat the hyperkalemia. My favorite ones is the K-Exalate. This drug used to be you take it by enema. Now you can take it orally. Thank God. I did not like doing the enemas. Orally, you can take it. The problem is it pulls K out through your GI tract and gives these patients terrible diarrhea. So it's not a fun one for them, but we give it when the K is very high. And of course, we want to consider antibiotics because it might be the appropriate medication to treat, especially for a patient that we have that has an infection such as one with pneumonia. Collaborative care continuing, we want to look at pulmonary hygiene. So what would that include? That would include coughing and deep breathing, positioning our patient, encouraging them to take fluids, to hydrate themselves, and then certainly we would consider suctioning them to remove any secretions that are giving them any problems. We may even have to resort to a ventilator, putting this patient on a ventilator to support them until we can get them stabilized. Patient education is going to be focused on prevention. Certainly, the more we can prevent these things, the better we can. Preventing any kind of injury, trauma, preventing exacerbation of their COPD or infection from pneumonia. All these things, if we can prevent them, that will help our patient. But this patient, we need to remember, is they are going to need rest, and also we're going to have to be sure to provide safety for this patient because they are going to be at risk for falls because their musculature is weakened from the high K. Also, it can cause confusion, so their memory will be affected. So safety issues need to be addressed. Metabolic acidosis. This is what happens with this type of imbalance is there is either a gain in the acids or a loss of the bicarbonate. So it can go either way. But what you see is the pH is going to be down, and there's several different things that can cause this. So some of the causes can be related to, I listed them down here, 4 of them, and then we're going to talk about them specifically. Oh, I don't think I do have that. I think I don't have a slide for the rest of them, so we'll talk about each one. The first one can be due to fat breakdown. And this is where the fat has broken down, it becomes fatty acids, and then it becomes ketones. And we see this in our diabetics. We also see this in our chronic alcoholics, as well as our patients that have severe malnutrition. Any person that is taking a low intake of carbohydrates can also exhibit this problem. So other things that can fall into this that maybe we don't see as much, but hyperthyroidism or a severe infection can also cause our bodies to break down more fat and put us into problems with ketones. Another cause can be from decreased kidney excretion of acids. This is caused by when a patient is either in renal failure or renal insufficiency. And so we definitely see this with our diabetics, both the fat breakdown as well as we see them with their kidneys failing on them. And then as their kidneys fail, they are unable to excrete those acids and they end up in metabolic acidosis. Third one is can occur when there are excessive lower GI losses. This can be from diarrhea. We definitely think about our C. diff patients. Any patient that has an intestinal malabsorption or has an ileostomy that's putting out a large amount of drainage, or even a patient with fistula. And we've had quite a few patients over at the hospital with fistulas. And so these patients fall into this category of being at risk for metabolic acidosis. They're losing a lot of bases, and this is going to a lot of bicarbonates, and they're going to be at risk for this. Another cause can be too much lactic acid. This we see with our patients that go into shock, as well as our patients in heart failure, and patients that have excessive seizures or strenuous exercise. We can see excessive lactic acid accumulating and causing them to go into metabolic acidosis.
Labs that we can see changed in metabolic acidosis, we will look at our ABGs. The pH will be less than 7.35. Our PaCO2 will remain normal because this isn't a respiratory focus, but our bicarb will drop. So we will see this to be below 21 or 22, depending on which range you're looking at. But remember, testing-wise, we'll go with 21. And so we'll see the changes in the bicarb as we're losing our bases. Electrolytes, the K may be high, maybe greater than 5.5. Remember that hydrogen is moving into the cell and potassium is moving out of the cell into the blood. So we will see it be high. The blood glucose will be elevated if we're looking at DKA. So if our patient is, the reason why they're in metabolic acidosis is because they're a diabetic and they're in diabetic ketoacidosis, we will typically see their blood sugar elevated, and it's not uncommon to see it to be greater than 300.
The treatment for this, for metabolic acidosis, is dependent on what is the problem. And we have quite a few different things that it could be. If it's diabetic ketoacidosis, we're going to administer a rapid acting insulin, and we're going to monitor the potassium levels. And because these potassium levels are going to drop when the acidosis is corrected. Remember that potassium is going to go back into the cell. So we're going to have to monitor that very closely because we can get in trouble with cardiac arrhythmias. We will consider giving sodium bicarbonate to help remedy this. And we will consider doing dialysis if renal failure or there's drug toxicity. This patient may need a ventilator because they may be decompensated so much on a respiratory level that we need to ventilate them. And many times I've seen this happen with our patients, that by the time we intervene, they are so compromised that we have to put them on a ventilator for a short period of time excuse me, to get everything stabilized. And then once we get everything stabilized, we're able to move them off the ventilator. The problem is especially with our respiratory acidosis patients, is that if they are compromised already due to a respiratory illness, such as COPD or emphysema, it's very hard to then get them off the ventilator, and that's a whole other topic that you'll get to address in semester 4. But here, if we have a patient with diabetes, they're in because they're in ketoacidosis, we're definitely going to intervene with the insulin. And if they're here for renal failure, we're going to intervene with the dialysis. That's the quickest way to make changes to this for our patients. Patient education, it's specific to the cause, and so this means we really want to work with our patient concerning their diabetes, compliance, and also intervening with their renal failure. Hopefully, if it's all based on diabetes, we can intervene early with this and prevent them going into renal failure. And here's one of my little pictures again, just giving you, some of you like pictures that help you to see things, but you can see with this metabolic acidosis, we're going to have the depression of the CNS, so we're going to have that disorientation, the change in the LOC, headache, the potassium as it drops, it says muscle twitching, I like to call it more muscle weakness. And in this one, we are showing the Kussmaul breathing that's trying to compensate. But the one I like the best is down at the bottom where it says your pH is going to be low and our bicarb is going to be low, and you can see it's all related to the kidneys. Let's look at alkalosis now. Alkalosis, let's look at the cellular pathophysiology of it, and then after we've looked at alkalosis, we'll then look at respiratory alkalosis and metabolic alkalosis. Now, alkalosis, pathophysiology on a cellular level, we're looking generally at the respiratory and the metabolic. And basically what it is there's an excess of base balance due to either there not being enough hydrogen or there being too much bicarb. So the first thing that we're going to see is we're going to see that pH is going to go up. It may not be the first thing we see, but the pH is going to be elevated above 7.45. As it elevates, it's going to stimulate the cardiovascular system. So you know where you see that alkalosis, the S at the end there, it's going to stimulate the cardiac vascular system. We will see the heart rate increase. We will see ECG changes. We will see the CNS and medulla being stimulated. And one thing that happens differently with alkalosis is there is vasoconstriction that occurs. And with that vasoconstriction, now we're going to see the blood flow being diminished, and as a result, we'll end up with hypoxia. As the pH continues to elevate, the hydrogen ion is going to move out of the cell because it wants to find that neutrality again. So as the hydrogen moves out, the potassium is going to move in. This is the total complete opposite of acidosis, correct? So this will help to correct the pH. It'll start to pull that pH down, but it's also going to end up dropping your potassium. So totally opposite responses here. Also, what will happen as that pH elevates, it's going to stimulate the kidneys, and the kidneys are going to try and excrete more of the bicarb and the sodium, and it's going to try and retain more hydrogen. And this will help bring our pH down as well. Another thing that ends up happening as this pH goes up, it inhibits calcium. And so as a result, there will be more, your neuromuscular excitability will be increased as a result of your calcium being inhibited. So let's look at signs and symptoms. Signs and symptoms, there you get, I have my little alkalosis with the S and the stimulation of the CNS, and so we're going to see stimulation of the CNS, neuromuscular, and cardiac system, and it's all related to hypokalemia and hypocalcemia. So as those potassium and calcium goes down, we are going to see these changes occurring. So in the CNS, we're going to see stimulation, we'll see hyperreflexia, totally opposite of what we saw with our acidosis, We're going to see irritability. One thing that we'll see is paresthesia. Well, typically you'll see this numb mouth and numb toes, and that's a really classic sign of our patients. And it can devolve into seizures. Neuromuscular changes that we are going to see are, again, related to the K being down, the potassium being down, and the calcium being down. With the calcium, we're going to see tetany and cramping. We're going to see a positive Chostek and Trousseau occurring. So those are things that you would want to remember to know how to do. We also will see because the potassium's dropping, we're going to see muscle weakness, and it gets to be that they're so weak that they actually have difficulty breathing. Cardiovascular changes that we're going to see also, again, being stimulated. We're going to see tachycardia and arrhythmias occurring. Respiratory-wise will depend on whether it's a respiratory or metabolic focus. If it's respiratory, we will see an increase in the rate and volume of the respirations. But if it's a metabolic, we will see the skeleton is getting weak, and so what will end up happening is you will see decreased respiratory effort. Now let's look at respiratory alkalosis, and then we'll follow up with metabolic. Respiratory alkalosis, the causes of this is hyperventilation is the main etiology, cause underlying all the reasons why people end up with respiratory alkalosis. There's some kind of hyperventilation that has occurred. And what ends up happening is they have blown off hydrogen, carbon dioxide, ending up with you having a very low CO2, also known as hypocapnia, another one of NCLEX. You should always remember this one. And also what ends up happening is your pH goes up. Now there's various different reasons why we can end up hyperventilating. We can hyperventilate because of fear and anxiety, even pain can cause us to hyperventilate, and the release of catecholamines will cause us to breathe faster. Typically what I would see in the school system is some girl would get her, and I'm sorry to be dissing the female gender, but some teenage girl would get upset about something and she would start crying and being hysterical and get herself hyperventilating, and literally she would put herself into respiratory alkalosis. And the signs and symptoms were just so classic. She would come in, she'd be breathing very quickly, she would be have all these signs and symptoms of the weakness and the numb mouth, the numb toes, very classic. Other reasons that we can end up hyperventilating, medications and substances can also get us in trouble this way. Nicotine is one of them that can do this, as well as aminophylline, which is a respiratory drug that's not as used as often as it used to be used, but it would stimulate us, stimulate breathing, and it worked very effectively, but now we don't use it very often. Another thing that can cause hyperventilation is the ventilator. Sometimes we put our patients on a ventilator and we have the rate going too fast. This was especially true, I think, until we got intensivists that would work in the ICU, doctors that was their only job, and they would manage the ventilators very succinctly. But before, when we would have generalists come in, it wouldn't be something that they knew about as much, and so the likelihood of that happening is much more likely. Although the ICU nurses, we would always say, hey, we need to slow down this respiratory rate. And of course, the ICU nurses work very autonomously and are able to check ABGs and make any adjustments to the ventilator settings as per their standard protocol. Labs that we will see, when those students would come in, if I had a penny, no, I didn't have that many girls come in with hyperventilation, but if I was to have done a blood gas on them, this is what I would have seen. I would have seen a pH greater than 7.45. I would have seen their CO2 low, because they had blown so much of it off from hyperventilating. It would be below 35, and their bicarb would be normal. Their electrolytes, I'd probably see their K be low, I'd see their calcium be low, and even the chloride could be down low. But typically we look at the first two more than the third. Treatment, we need to treat the underlying condition. If it's anxiety, well, then we need to help slow them down and help them not to be so anxious. Maybe we need to sedate the patient. We certainly need to stay with the patient and help them with their anxiety. If they're hyperventilating, you can have the patient breathe into a bag. This forces the patient to breathe exhaled carbon dioxide. This helps to raise their CO2. Now, I know that there have been some concerns that we could end up getting a patient that's hypoxic, even more hypoxic, but the percentages are in our favor here, that the patient, if they're hyperventilating and they've got the signs and symptoms of the numb mouth, then having them breathe into the bag is a good idea. But it's always, nowadays, we have these oximeters, O2 sats everywhere, the portable ones, and we can just hook a O2 sat right on them and see what they are. If they do have an O2 that's low, we need to intervene with oxygen before we end up having them breathing into the bag. And that's an exception to the rule. I just want that in the back of your mind, just like you don't throw the O2 up to 10 liters on a CO2 patient. A COPD patient. Okay, hyperventilation. So I told you about using the bag. Also, if they're on a ventilator, we would adjust the ventilator settings. We would decrease the tidal volume, decrease the number of breaths, so that we could slow them down. And this is something I believe you actually get to do all this in third semester with Sue Simpson. You will monitor their vital signs, of course, and check and make sure if they do have any low oximeters, O2 sats, you're going to give them oxygen. And of course, you're going to provide rest after the respiratory rate returns to normal. And typically, most of these patients that would come into the school office, they would settle down, and about an hour later, they could get back to their class. Patient education, well, anxiety reducing techniques is a good idea, and controlled breathing techniques is another one. And there's another picture of respiratory alkalosis. We see the hypokalemia, the hyperventilation, the rapid breathing, and the tingling of the extremities, and really the classic tingling around the lips. They think something's really going wrong with them, and it's typically just that hyperventilation. Metabolic alkalosis, the causes of this are some kind of loss of acid or excess excess bicarbonate in their body. And this can occur whenever you have vomiting or gastric suctioning. So what they end up doing is they're losing a lot of acid because above the waist they're going to lose acids, below the waist they're going to lose base. And so if they're vomiting or doing any kind of NG suction, we're going to be pulling out the acid and lowering that amount, and can put them at risk for metabolic alkalosis. Medications can also get them in trouble. Any kind of excessive ingestion of antacids, because they are a base, they are going to increase the amount of bicarbonate. Corticosteroids will also get our patients in trouble, as will diuretics that deplete potassium, such as our loop and thiazide. Diuretics can cause problems. The most common ones that I see here are really the antacids and the vomiting and gastric suctioning. Labs, pH will be greater than 7.45 because they're alkalotic. Their PCO2 will be normal because it's not a respiratory issue, but their bicarb is going to be elevated because it's going to be higher than 26. Your electrolytes, you'll see the potassium is going to be down. Remember, as the alkalosis resolves, that potassium will go back, so you kind of have to watch out that you don't overcompensate for this patient. Calcium will be down, chloride will be down. Treatment, well, it's to prevent further losses. So, if your patient is losing through a thiazide diuretic, well, then we need to maybe change the diuretic. Or if they have NG suctioning, we may need to consider having some kind of replacement for that. Also, if the patient is vomiting, we need to consider antiemetics. We certainly need to restore their fluid balance. And we can also consider the drug Diamox, which I haven't seen too much of recently, but Diamox, it will increase the excretion of bicarbonate by the kidneys. So that will help lower that pH. Patient education, well, if the problem is due to any kind of medications, we need to talk to them about looking for those adverse effects from diuretics. If they're using antacids, we need to really talk to them about not overusing them. This is a very common problem because a lot of people have gastric upset. Rather than going and seeing the doctor, they just take the antacid, the Tums, whatever it is that they can get over the counter, and then they can abuse it and take it too long and get themselves in trouble. It takes a lot, though, to get you in trouble. Our body is pretty amazing. So let's look at some memory joggers that'll help you to remember some of these numbers and things. The first one is the normal pH levels is 7.35 to 7.45. Do you see the 35 to the 45? And so the middle of that is 7.40. These are not my memory joggers. These are hopefully will help you. Normal PCO2 is 35 to 45 as well, but you see it's not the 7.35 to 7.45, but you can see there's a common thing there. Another thing for a memory jogger is that the PCO2 and the pH move in opposite directions. Um, so usually as you see the PCO2 go up, the pH will go down, and if the pH goes up, the PCO2 will go down. Bicarb, on the other hand, moves the same direction as pH. So if the bicarb goes up, the pH goes up. If the bicarb goes down, the pH goes down. So these are some things to kind of just keep in your memory. It helps you to be able to make some decisions when you're looking at blood gases. Here's another one, the acid-base referee illustration. This is where the referee calls the shots if the acid or the base is lost. If it's above the waist, acid is lost. A, above the waist, A, acid is lost. If it's, and things like that would be stomach containing HCl, so vomiting or NG suctioning will result in hydrogen loss and alkalosis, or even lungs hyperventilating will cause the loss of CO2 and result in alkalosis. Below the waist, base is lost. So B, below the waist, base. Bowel contains alkaline substances, so the diarrhea results in bicarbonate loss and acidosis. Okay. How do you interpret an ABG? So I'm going to teach you one method. There are other methods out there. Actually, I'm probably going to show you two methods. One will lead to the other. But there's also one called tic-tac-toe. That's a very good method, and it's really good for compensation. But I'm not so sure it's good for the beginning. So I'm going to think about that one for a while, but I'm going to teach you this way because this has worked for most students over the years. How do you interpret an ABG? Well, there's three numbers that you're going to look at that are related to acid-base. The three numbers that you're going to look at is pH, PCO2, and bicarb. So you can see these are the numbers, and these are the numbers that you need to have memorized. There's going to be three steps to checking your ABG and making a decision on what's wrong. You're going to check the pH. Is it abnormal? Yes. Is it below 7.35 or is it above 7.45? If it's below 7.35, that means it's acidotic. If it's above, it's alkalotic. So we've already made one determination. We've already looked at a blood gas and we've already decided whether it's acidotic or alkalotic. Now we're going to decide in the second part of this what system is causing the problem. Is it respiratory or is it metabolic? And what we first do is we look at the PCO2. So we're going to look at the CO2 and we're going to say, is it high or is it low? And how does it correlate to the pH? Now remember that rule, that if the pH is down, the CO2 will be up. If the pH is up, the PCO2 will be down. So we're going to look to see if there's any kind of correlation there. The next thing we're going to do is look at the bicarbonate level. Is it high or is it low? And how does it correlate to the pH? Remember, we have a rule about this. Metabolic, if the pH is down, the bicarb will be down. If the pH is up, the bicarb will be up if it's a metabolic problem. Now here's some little ways to remember this. We have Phoenicia and Paco that are on the seesaw, and you can see pH, when it goes down, the PCO2 goes up. So when Phoenicia goes down, Paco goes up. When Paco goes down, Phoenicia goes up. Did I say that right? Up and down. Anyway, over here on the swing, we have Carbo and Phoenicia again. And Carbo is your bicarbonate. And Carbo, when Carbo goes up, Phoenicia goes up. When Carbo goes down, Phoenicia goes down. They go together always. So let's look at this picture. And you can see here, this is the Mnemonic, Rome, R-O-M-E. A lot of people like to use this. I think it's an excellent method. I didn't learn this one, but every so often I'll go back to it because it is a really easy way to remember it. Remember, RO means respiratory opposite, ME, metabolic equal. So remember, pH goes up, just repeating just exactly what I just said. Respiratory is always opposite in pH, metabolic is always equal, so your bicarb will always be the same, moving in the same direction as your pH. So when we look at respiratory acidosis, let's look at this and we'll say, we're going to look at this example and see. pH, we're going to do our steps. The first step is pH is 7.25. Is that normal? No, it's not normal. It's low. So if it's low, does that mean it's acidotic? Yes, that's what it means. So we can immediately say right away the patient is acidotic. On the PCO2, is this normal? No, this is not normal. This is elevated. So we know that it's very high. So we know the pH is down and the PCO2 is up. And so that means it's respiratory opposite, right? So this is looking to me like a respiratory acidosis. But then let's look at your bicarb and see if that confirms it. Well, there is our bicarb, and our bicarb is normal. So we can easily say that this is respiratory acidosis. Now, if there was compensation that had occurred here, well, then everything changes, and that's where that tic-tac-toe method actually is pretty good, and I'll give you the website so that when you get into third and fourth semester, you can use that if the instructors don't refer you to it. But just starting off with the basics, this is the method that I've always used. I also look at the patient. It's very easy when you see a patient that's in for pneumonia or COPD to know that the problem is respiratory based, but the blood gases prove it out. So now as you hit the buttons, you're going to see that the arrows will show you how this is.
Now let's look at metabolic acidosis. We have an example here of some ABGs. The pH is 7.20. So what is that? Is that acidotic or alkalotic? Well, we know it's below 7.35, so it is acidotic. So let's hit the button here, and here comes the arrow. Okay. On the next one is we see its PaCO2 is 40. We know normal is 35 to 45, so we know that this is normal. So we will hit the button again, and here comes that arrow showing that it is neutral. And then lastly, we're going to look at our bicarb 15. Well, we know normal is 21 to 28 or 26. I can't remember that top number. I better remember it, huh? So when we look at that, we want to be able to say 21 to 28. We know that this is low. And so hit that button again. Here comes the arrow. So we look at our pH is down, our bicarb is down. We know that they swing together. And so that means that this must be, we already knew it was acidotic. Now we know it's metabolic. And so here is the metaphor showing there, Rome. Not the metaphor, but the an acronym, MNEMONIC, ROME. Here we are with respiratory alkalosis, and so let's look at the pH. Is it acidotic or alkalotic? Well, it's over 7.45, so it is alkalotic. Hit the bar, space bar. There we go. It's up. Our PCO2 is 30, which normal is 35 to 45, so this is down. Hit the button there. And then lastly, our bicarb is within the normal range being 21 to 28, so we're going to indicate that with a neutral arrow. And so this means that this is pH is going up and the CO2 is going down. They're in opposite, so it's respiratory alkalosis. Looking at our last one here, metabolic alkalosis, well, we're going to have that pH up, right? hit the button there. We are above 7.45. Our PCO2 is going to stay neutral or within normal ranges, which is between 35 and 45. And lastly, bicarb is 30, and that is elevated. So you'll see that the pH and the bicarb are going up together, and so we know it's a metabolic origin. And there we have it, Rome, metabolic. pH and bicarb are equal or go up.
Other lab values that we want to consider are our PaO2. This is also another blood gas. Oxygen levels. It's normal should be between 80 and 100. It's not. We're not talking about O2 saturations. This is literally the oxygen in the arterial blood, and so we want to see what they are running. 80 to 100 is what we consider normal. And so we certainly want our patient to not be hypoxic, and so we're looking for that. We're also looking at our O2 saturations, looking at the percentage of hemoglobin that's carrying our oxygen, and we certainly want that to be normal, above 97%. Another lab value that we can see is our base excess, BE. This will tell us the degree of acid-base imbalance. We normally should be between -2 and +2. We use this a lot for trying to figure out compensation. Except, like I said, I just found that new method with tic-tac-toe, and I think you don't even have to use base excess to be able to do that. So I'll have to show you that method. Anyways, let me see what else I might need to tell you here. Nope, I think that's it. So this concludes our lecture via PowerPoint tomorrow, or hopefully you're not listening to this the night before, but what we're going to do in class is we're going to go over blood gases together. We're going to do some blood gases as teams, and we're also going to do some different activities and some case studies that will hopefully help you to solidify this learning that you just had on the PowerPoint. So have a great evening, and I will see you in class. Thank you.